Welcome to Code Management Part 1 of 2. This is a section for the cardiovascular section of this course.
The objectives for this particular presentation are that you should be able to explain the related signs and symptoms of the management and evaluation of clients with alterations in ECGs. Know that dysrhythmias, lethal dysrhythmias, such as VFib and V-tachycardia that's pulseless, versus arrhythmia means there's no rhythm or an alteration in the rhythm, which would be asystole or PEA, pulseless electrical activity. Some people call it EMD, electrical mechanical dissociation. So let's do a case presentation. So the nurse has just finished doing morning rounds on a cardiac step-down unit when Mr. A 76-year-old patient, turns on his call light. He states that he is having chest discomfort and is feeling nauseated. The nurse starts to ask him to rate his chest discomfort. He suddenly grabs his chest and collapses. The nurse pushes the code button at the head of the bed on the wall and starts CPR immediately when she notes that there is no pulse. The code team arrives and a respiratory therapist places a bag valve mask, or what we can call an AMBU bag device, on the patient to provide oxygen. The ICU nurse notes the rhythm. The rhythm is fast with a wide QRS complex, and it is regular, monomorphic, meaning it looks the same. This is the rhythm that the nurse notes on the monitor. See that the QRS complex is widened. There's really no P waves or ST waves. And when the nurse is checking the pulse while looking at this, she says there's no pulse. The patient's not breathing. So what do you think are our concerns? First of all, you have to have a pulse and you have to have breathing to have life. So what do you think this rhythm is? This rhythm is V-tach. So a code can be designated by a number of different nomenclature. Majority of the places I've ever heard, I've always heard code blue, code 99, and Dr. Hart. It could be either cardiac or respiratory arrest, or it could be both, a full-blown cardiopulmonary arrest. Life-saving resuscitation and intervention is needed. CPR is your BLS, your basic life support, with AED, the automatic electronic defibrillator. ACLS, it is the advanced cardiac life support. Those are people that are trained further beyond basic CPR. They're trained further with regards to life-saving defibrillation, medications, and oxygenation provisions. It is guided by hospital policy and procedures, but it's based on standards from the American Heart Association, who also gave us our BLS standards. So when you're in a facility, you want to know what is the notification policy, who leads the code, who can and who cannot defibrillate a patient, who cares for the patients during the code arrest, and what does the nurse who's taking care of the patient there, what is the responsibility that they have? The code team is really a team, and it's made up of its individual members. The ideal team has a physician leader, not necessarily an MD, it could be a DO, but a healthcare provider that is a physician leader. Sometimes that is now being changed so that a nurse practitioner can be the leader. But they must be skilled in ACLS, and all facilities are requiring that they have ACLS certification. Respiratory therapists are part of the team. Pharmacists, you will not find pharmacists at night the majority of the time, but many facilities are having satellite pharmacies, so a pharmacist generally will try to show up at a code and help with the drips and the medication administration. Ancillary staff, such as you may have a CNA or a PCT who helps with CPR, doing the actual compressions. You will have radiology. You will have lab. Respiratory will do ABGs. Those are the people that are going to come and be available for when you need something immediately. You don't want them all in the room, but they can be waiting out in the hall. The nurses that you definitely want to have the nurse that is caring for the patient as part of that team. They are the brain of that team. They are the person that knows that patient the best out of the entire team because they know the history. They've been there with them. They know what happened. The other primary nurses that should come is an ICU and an ED or ER nurse. The primary nurse, again, knows that patient. They need to be available to provide that succinct update and answer any important questions. The second nurse that arrives, either an ICU or an ED nurse, is generally going to be the lead until the physician arrives or the primary provider. And then they are also going to be the person who gets equipment from the crash cart because that's where the medications are, and they will run that. Medications, the other equipment. Another nurse will be responsible for recording the event. That is the recorder. Many, many times that will be the house supervisor if they are not controlling traffic, but many times it is the house supervisor, especially at night because of the limited number of people available at night compared to during the day. But you do have to have a recorder to keep up with what was given, when it was given, and you will be able to provide feedback whenever they say, when was the last epi, because of the timings that need to go in there. Again, nursing supervisor or someone else needs to provide traffic control because if somebody calls a code and there's an emergency, everybody in the entire hospital's adrenaline is going to rush and they all want to help. And so if you get like 14 respiratory therapists, I'm sorry, but I only need a maximum of 3. And I mean a maximum of 3. Go away. I have PCTs. I have CNAs who can help me do CPR. I need to swap them off, but not all of them need to be right there. I need to be able to move people in and out of that room. I don't need looky-loos. I don't need patients in the way. So if this is a semi-private, somebody needs to get that other patient out. If there's family there, we need to get these people moved away from the room. We need to give the people space to appropriately function in their roles. Make sure that a lot of times if a patient needs to go to a higher level of care, this is arranged through the house supervisor. They are responsible for assigning personnel to care for the family present during the code. That may not be the house supervisor. It may be whoever the leader is. But somebody needs to be the leader, or it will be chaos. The equipment that is needed is, number one, the crash cart, because the crash cart has everything that you need on it, including a backboard. Some of the older metal ones have a backboard on hooks in the back. Some of the newer plastic ones has a plastic one in the front that locks all the drawers, and you just have to pull that out. You want to take that and you want to put it underneath the patient to give you a firm surface to push against to get good chest depth for your CPR. You want to have a monitor defibrillator pacemaker. If you don't have that, you want to have an AED. Now, if you're in the hospital, you're going to have a monitor defibrillator pacemaker that does have AED and transcutaneous pacemaker capabilities. That has almost become standard throughout all of the nursing units, especially for cath lab, ICU, and ER. Now, if you're in a long-term care facility, something like that, you may only have a monitor defibrillator pacer. You may not have AED mode, or you may not have transcutaneous pacing possibilities. It may just be a monitor defibrillator. You need to have a bag valve mask device or an AMBU device. You need to have other airway supplies, which are Yankauers, sterile suction tubing, or a kit. You need to have multiple sizes of airways, oral, nasal airways. How about an endotracheal airway? Multiple sizes there because those are size dependent for the patient. You need to have the metal piece that inside called a guide wire to help strengthen the ET tube so that it goes in. Then you pull that out and supply the oxygen. You need to have ability to suction a patient, so you've got to have suction available. If it's not on the wall, you've got to have a portable suction device to be able to have that. Medications, those are generally prepackaged into the med code cart. However, if you don't have a code cart, then you need to have a medication box available. IV supplies, you need to be able to start IVs. So you need to have IV catheters, you need to have IV start kits, you need to have dressings, you need to have bio patches, and then of course other IV access. What if I need to put a bigger line in? I need to have some kind of a triple lumen or some type of large bore to go jugular, or maybe even an introducer percutaneous line to be able to get into a large bore. How about a nasal gastric tube? If we need to decompress the stomach, or we need to prevent the patient from aspirating and throwing up while we're doing CPR, sometimes we'll be able to put an NG tube down right away if they are starting to throw up. Otherwise, they will put an NG tube in after they have been intubated. You definitely have to have a working blood pressure cuff. And I don't necessarily mean just the automatic ones that you have. You need to have a manual manometer available in case you need to use it. And so that means everybody needs to have a stethoscope somewhere, either on themselves, in the room, or on the cart, to be able to do a manual blood pressure. This is a picture of what one code cart might look like. And if you will look at the front of the code cart, there's all kinds of labels telling you what is where. Now and if you'll see the little blue things that are on the bottom and on the right hand side, those are plastic locks to keep them locked and secured. There's a needle disposable unit on the left hand side. We've got an IV pole up at the top, and then we've got our two boxes. Here's my concern with this. Do you know and do you have time to read all of those labels in an emergency? No. You need to be very familiar with this information, so you need to do it beforehand. That's one of the things that you need to start preparing yourself to do during orientation in whatever facility that you're hired into. You want to become familiar with the code cart and what is in it and where it's located, so that you can be better prepared during an actual emergency. You don't want to be shuffling, seeking, and finding during the actual emergency. You want to do that before the emergency so that you're familiar with it. So for ACLS, one of the biggest things I need you to remember is that I need you to treat your patient or your client, not the monitor. Whatever you see on the monitor, you need to confirm or not confirm that with your actual patient. And anytime you're doing ACLS, CPR must be maintained throughout. Now, if you're told to hold for an assessment or procedure, you will hold, and then once that is finished, you immediately return to CPR. It is important that you maintain CPR as you were trained. So you need to have that good depth, 1.5 to 2 inches, and it is preferred that you hit that 2-inch mark. And then you need to do it fast. You need to do it 100 compressions per minute, or maybe a little bit faster, but you don't want to go too fast. You need to rest. You need to stop and completely come off the chest, actually completely relieve all pressure off the chest, but leave your hands on the chest, and to allow recoil, allow the heart to cause that vacuum and suction the blood back into the heart from the superior and inferior vena cava, so that we can get more blood in, get it to the lungs, get it oxygenated, and get it back out. So you want to change whomever is doing the compressing about every 2 minutes. That's because at the beginning everybody's got code, they have a lot of adrenaline, but this code may go on for an hour or more. So we do not want everyone totally exhausted. So 2 minutes, change your compressor. 2 minutes, change your compressor. And you want to make sure that you're not going too fast or too slow. There is a song that you sing. It's called Stayin' Alive, Stayin' Alive, ooh, 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 Stayin' Alive. That is a good beat. That gets you at the number that you need to be, and it'll allow you to have a good steady rhythm. Please know that early defibrillation is essential, and I do mean essential, for saving people's lives who are in VFib and VTach rhythms. If they are in an asystole rhythm, do not You will not get them back. You want to make sure that you establish an IV or an IO. An IO is an intraosseous treatment. They try not to do endotracheal medications anymore because we know that this causes acute lung injury. That is a last option choice, and it is very quick to get IOs in now with the new drills that they have, and they are very much less painful than they used to be. You want to provide your treatment based on what is wrong with your patient, and there are established advanced cardiac life support algorithms that will guide you throughout each of the rhythm treatment processes. This particular picture is showing you what a Philips defibrillator system looks like. There's also a Baxter, there's Puritan Billet, there's Zoll, there's all kinds of them out there, but they all have standard procedures. But again, you want to be familiar with this equipment prior to a code. And this one in particular has very, like the lightning bolt there, that is the actual shock button. You have to turn the dial to what you want. Number 2 is to charge it, and number 3 is to shock someone. And this is for a hands-free shocking, and that is the goal. For majority of the time, we prefer that you be hands-free shocking, because too many other bystanders, including the person trying to rescue the person, has the opportunity to become damaged or injured or shocked themselves. So, what happened during the code? Well, remember, our patient went from pulseless VTach or pulseless ventricular tachycardia to sinus rhythm, still without a pulse, and then they went into asystole. So what does this mean for our patient? What this means for our patient is that we continually deteriorated. We were in VTach. When we did get a rhythm back, we got electrical activity, but we didn't get muscular contraction. Then we went asystole, meaning even the electrical impulse stopped. And so that's what the series of means. That means if I can't get any muscular activity, I am not going to be able to successfully resuscitate this patient. I've got to have muscular response to that electrical impulse. If I have electrical impulse without muscular contractility, I will not be successful. So now let's look at this rhythm here. What do you think this rhythm is? It's VFib. How do I know it's VFib? I don't. I need to confirm. It's got a wavy baseline, but could this possibly be an asystole? What if it were smaller and flatter, more of a finer VFib? I would have to check a second lead to confirm that it was asystole and not a true VFib somewhere else. This is VFib because of the baseline. There's no true QRS complexes. This is VFib. You have less than 10 seconds to determine if there is a pulse or not with this. Generally with VFib, there is not. So the algorithm determining the care for a patient with ventricular fibrillation or VFib, the first thing, of course, is CPR. Then you want to determine if the rhythm is a shockable rhythm. If it's VFib, it is. If it's not, it is not shockable. This is VFib. It is shockable. We want to shock it. We want to defibrillate this rhythm. We continue with CPR. At that point, we are going to ask for epinephrine. Epinephrine, 1 to 10,000, you're going to give 1 milligram, which comes prepared in a Carpuject, and we will talk more about that in class. Now you want to repeat step 2. You want to shock the patient. Then, which is determine if the rhythm is shockable again. Then shock it. And then you want to keep repeating this over and over and over. CPR. Is it shockable? Shock it. CPR. Give an epinephrine. Now determine if it's shockable. If it is, shock it, but with a higher juice. Depends on whether this is a monophasic or a biphasic. Almost all systems have gone to biphasic now, which means that you're going to start at 50 joules, then 100, then 150 to 200 joules. You want to keep going at a higher juice until you reach the maximum. If this is a monophasic, you will be at 150, 200, and then 300 or 360, depending on what the highest is. The drug therapy, either IV or IO, again, you're going to give epinephrine 1 milligram. You can give that every 3 to 5 minutes. Now, vasopressin 40 units can be used to replace either the first or the second dose of epi. The problem is, when you give vasopressin, you have to be patient and wait for it to be metabolized and circulated for it to work. I typically do not use vasopressin. I know many other people do not use vasopressin. I try to stick with the epinephrine because I can give more of it faster and get it in and get better. What I feel was a better reaction. Another medication that you need to be very familiar with. You need to know these drugs. Epinephrine, how much you're given, how you're giving it, how often you can give it, and why you're giving it. Vasopressin. Also, amiodarone. Amiodarone is the drug of choice that is recommended for VFib and VTAC. Your very first dose is 300 milligram bolus, and then you want to shock your patient. If you convert, you want to start them on an amiodarone drip right away. If not, if the patient didn't happen, then you're going to give a second dose of 150 milligrams. And then, if that doesn't work, then you have to continue following the algorithm. So we talked about defibrillation. What does that exactly mean? Well, what happens is we are applying electrical impulse to the body to completely depolarize every cell in the heart. This allows for the resumption of a normal regular rhythm when the heart does return. Please know that safety, patient safety, and other people's safety is essential. Complications from this could be skin burns, heart muscle damage because you're actually burning it and shocking it. All the other complication, not necessarily patient complication, but another complication could be a person in the room helping you might have been touching the patient, a piece of equipment touching the patient, or the bed touching the patient. And if you do not shout all clear, whomever is pulling the trigger on this defibrillator, if you don't shout all clear and ensure that everybody is all clear, you are going to have a second patient to care for at the same time. External paddles, so the outside paddles, you see those on TV where they rub them together with the gel and you go all clear and boom. I will tell you that most of the time in the hospitals have now gone to hands-free or hands-off defibrillation with multi-purpose pads. You put them on and they stay on. We don't use gel anymore. We actually have defibrillator gel pads that we put on, and we use those over and over, because before we used to have to get the gel to do the conduction, and you had to do it every time that you did another shock, and it actually lengthened the time that it takes to get the process completed. Whether you're using a paddle or pad placement, you are going to be putting them in the same place. You will do a transverse interior, meaning you will be in the top right hand section, the patient's top right, or your left hand will go to their pectoral area, just above the nipple, up on the pectoral chest with your left hand. Your right hand will be on the patient's left thoracic area, just below the heart. So you're going to sandwich the heart between those two pads. Now, the anterior-posterior way to do that would be one on the front and one on the back. And you want it so that you go, you'll do it just a little bit to the left on the pectoral area so that you still have a place to do CPR on the actual bone, because you don't want any of these patches on a bony prominence, because bone is so thick for the electrical impulses to go through. You want it to go through muscle. So you want to put it up on the pectoral a little bit, and then you want to put it on the back. The posterior one is on the back, just to the side of the spinal column. So, again, your paddle or defibrillator pad placement is very important. You want to have good contact with the skin because that helps you protect from burns. So if you have a conductive medium, like I said, we used to use the gel and you would smear it on the paddles, and then you would put pressure, like 20 pounds of pressure pushing down on those pads to help conduct that impulse through the muscle, and you would trigger the impulse. Now that they have hands-free, they have a wider area of impulse, they have a wider area of conductive gel, or those good jelly patches that they can use. You want to make sure that you have them in a good place and you have that conductive medium. Then you want to charge the defibrillator at the desired setting. You want to make sure that you say, I'm clear, you're clear, everyone's clear. That oxygen is clear. You have adequate pressure on the paddles if you're using the hands-on paddles. You want to shock. Then you want to do CPR for 2 minutes, assess the rhythm, and if it's something shockable, you want to go through this process again. So now you shocked your patient, and you're assessing your patient, and all of a sudden we have a rhythm. This is what you see, and you see there's a P wave, a little bit widened PR, so maybe this is a first degree. You see a QRS and a T. Oh, good. So the leader says, hold CPR, and you check a pulse, but there's no pulse. Now what? What do we have here? We have pulseless electrical activity known as PEA. Another name is EMD, electrical mechanical disassociation. CPR is the key here. You want to give them epi. Everyone who ever codes gets epi. Everyone gets epi, epi, epi. The airway is preferred, so you want to do minimal interruptions to compressions to advance your airway. So you want to maintain airway, use an airway and the ambu bag and use that, because CPR is a great way to get somebody back from PEA or EMD. You want to treat any underlying cause, and that means you're treating the H's and the T's. So what are those? Well, we call those the 5HTs. 5 H's: hypoxia, hypovolemia, hypothermia, hydrogen ions, meaning acidosis, or a hypo or hyperkalemia. And then the 5 T's. We have tamponade, we have intention pneumo, we have toxins, or we could have a thrombus in the heart or thrombus in the lung. So that concludes our pre-lecture for code management in preparation for your lecture on Monday. Please make sure that you read both chapters